Duchenne muscular dystrophy is the most common congenital muscular dystrophy. The incidence is 1 in 3,500 to 1 in 5,000. It's the typical X-linked disease. It's an X-linked recessive disease, which means that the patient will get the mutation from his mother, not from his father. The common symptom that usually the patient will present to you in the clinic with is difficulty walking or delay in walking. Other symptoms that you might notice in your patient is 1. He's not able to walk by 18 months. 2. Walking in his tippy toes or his toes. 3. Having difficulty getting up from the floor, or we call it Gower sign. With other symptoms may be pain, especially at night, more than what we see with a typical growing pain. Once you see that in your clinic, the first thing you have to think about is Duchenne, especially if he's a boy, and you have to throw a CK, you have to do a creatinine kinase level. Now, by definition, Duchenne patient, they have very high CK, more than 5,000, sometimes up to 15,000, even more. So if you do that and the CK came back positive or very high, that's most likely you're dealing with the Duchenne muscular dystrophy. So if you do that and the CK came back high, that you most likely are dealing with the Duchenne muscular dystrophy. How to confirm that? You have to do genetic studies. We used to do muscle biopsies to look for the dystrophin. We don't do it anymore due to the advancement in genetic diagnosis. So what you do is you do a genetic study. You start with the MLPA, looking for deletion duplication, which in order to not to miss any mutation seen in Duchenne. So if you do that and the genetic test came back positive, then you have your answer. If the genetic test came back negative and you're quite sure that what you're dealing with is Duchenne, you have to do a muscle biopsy then. Or if you're not sure it's Duchenne, maybe it's a limb girdle muscular dystrophy, you can do whole exome sequencing. Now, regarding treatment, so you have your patient, you diagnosed him, you confirm the diagnosis, you have to treat the patient. So to manage the patient, 1, you have the medication arm, so what medication you're going to use for this patient, and also you have the non-pharmaceutical arm. Starting with the second arm first, 1 is you have to disclose the diagnosis and counsel the family about the diagnosis. 2, you have to involve cardiology for dilated cardiomyopathy that the patient might have. You have to involve pulmonology for possible sleep apnea which might the patient develop later, and also orthopedic for possible orthopedic complications including scoliosis. The medication, we have steroid because we believe there is an inflammation around the muscle, so you can use steroid. And this problem with the steroid is a lifelong treatment. The steroid is going to delay the progression of the symptom by 2 years maximum or 3 years, so they delay the loss of ambulation by 2 years. Other newer treatment, we have a couple of new treatment. 1 is antisense oligonucleotide, which the idea of it is trying to skip the mutation seen in the dystrophin gene. So instead of not having dystrophin completely, you might have a shortened but functional dystrophin, and that has been the medication has been approved by FDA, and we do have it in Saudi Arabia, the eteliprusin. That's for 51 amenable mutations. We have a newer treatment coming soon for 53, and another third one in few months for 45 amenable mutations. Other treatment that's been available to and been approved by EMA in Europe is atelorin. That's mainly for nonsense mutation. Both of these medications, or all of these medications, they are not a cure. They're going to delay the symptoms. They're not going to have the steroid side effects that we usually see, but again, they're not a cure. They might prolong the symptoms or delay the loss of ambulation by 4 years, like what has been seen in atelorin, or maybe 3 to 5 years in eteliprusin, but again, it's not a cure. The cure hopefully is going to come over the next couple of years with the gene therapy using microdystrophin, inshallah.